Good afternoon, everyone. We'll move on to our next IC. So, the IC is on practical tips and pearls for eye hospital planning for NABH. So, our normal NABH training course goes in for 3 to 4 days. We have tried to shorten and bring around the capsule of all important points for you, which will be covered in next 1 hour or so. It is already a good discussion point for people who are in process, but I believe it will really benefit people who are planning to go, because you will have a limited information beforehand so that you can plan effectively. So I'll invite the instructors for the course. We have Dr. Nirmal Frederick with us. Dr. Nirmal Frederick is incoming president for TNOA. He has his practice in Tamram, Chennai. He's a member of IMA and also the chief architect of NABH eye care standards. We have all learned from him, and I feel he's one of the best person across India to talk and learn anything about NABH. We have Dr. Kumran. He's owner of Kumran Eye Hospital, and he has a very keen interest in OT and sterilization technique. Kumran, sir, not coming. Anyone? No one wants to come up. We'll present from there. Okay. So, okay. And so we start, sir? Okay. Dr. Sean De Silva, he's medical director of ASG Eye Hospital, Goa. And if you really like him, he'll invite you to Goa to enjoy. He'll be talking about some pain points and certain common questions which you will have, and he'll also lead the panel discussion for you. Dr. Shakeen Singh from Amritsar will be talking about the assessment process. If you're having an assessment, how you should behave, what you should arrange during assessment so that you really don't have problems. So he'll be sharing his experience with that. Incidentally, Dr. Shakeen, Dr. Nirmal, me and Sean, all of us are NABH assessor. So we have really gone across and assessed lots of organization, and we'll definitely be happy to share our personal experience with you. So I'll take up the first, I'm Dr. Gagan. I work at Narayan Netralaya, Bangalore. I had the Orbit Oculoplasty Oncology Services. And NABH is something where we all like to do honorary work because we believe in quality. We like and we feel that it has benefited us, and we like to get other patients and other hospital also to benefit from it. So these are my financial disclosures. So the first thing, IPL is going on. So IPL rules are different from ICC rules for, let's say, T20 and 50-day match and test match. But we all play gully cricket, and gully cricket has its own rules, right? One tip, one out. You can't hit the ball. If you hit a ball onto a particular side or boundary, you're out. So the whole thing is, to play a game, there has to be a set of rules, and it's a mutual set of rules agreed upon by everyone, right? So this simile is what we are going to talk next. And these are some of the abbreviations which all of us are going to use, and you will find it being used in other courses and WhatsApp and whatever, which says, what is SCO? SCO is an healthcare organization, means a big hospital, more tthan 50 beds. So all big hospitals are SCOs. SHCO is a small healthcare organization, which means it's less than 50 beds. And ECO is an eye care organization. So whenever you go to all our state level meetings and all discussion on WhatsApp, this is what you're getting. So these three terms, please remember. And these are the rule books, right? So if you are going in for NABH accreditation, you have different set of rules. So you have eye care book, you have small healthcare organization standard. You have a pointer, please. So this big one on the left, you see, this is the big book for big hospital. This is a SCO book, and this is a mother book. This is the entry level book, the basic standard which we all try to get. And this is the eye care standard book. So eye care standards are more suited for our kind of practice, because if it's a standalone eye hospital, we have certain different ways of working from other hospitals. This is what you will get in all standard books. So if you will open any of these 5 books which are applicable to us, you will get 10 chapters. So all books have 10 chapters. So these are the These are the 10 chapters. So all book will have first 5 chapters like this. This is 5. These are all what we call patient-centered standards, or this is where the clinical things would be there. These are more management-centered, organization-centered standards. And these standards are all abbreviated. So this is the next thing which you have to remember. So when someone says AAC, they are referring to the first chapter of every book. Every book first chapter is AAC. Okay. Now, why did we come across to this difference? So this will give you an idea now. A healthcare organization standard, what we saw, has got 651 objective elements. Means that we check in for 651 points during assessment. Whereas if you go in for an entry level, it would be 149. And an eye care has a check like 305 applicable elements which you are going to check. So they are all going to be different. And an important thing is, I can give you a real example which is often repeated whenever I talk. Two of my students have a hospital which is about 2 kilometers apart on the same road in same locality. And both of them underwent their NABH assessment at a gap of few days. And they met on a Sunday, probably having food and drinks together. And then they ended up saying that, my assessor was good, my was bad, he told me this, you have not this and something. So went on for a while, then they picked up phone and called me. And I also got, I said, this is not possible. Then I said, okay, where you have applied for? So one of the gentlemen has applied for entry level, which is only 149 elements. The other person has applied for eye care, which is 305. Right? This is accreditation, this is certification. So obviously, this gentleman will not have many things required for him because we are not going to check on that. Right? So when assessors are coming, or assessments are happening, or programs are being conducted, please understand what is applicable to you. If you are taking this rule book, then we follow this. You can skip all the things which are mentioned here which are not applicable to you. So where are you going to start? And where are you going to get these standard books? These are all freely available on NABH website. So nabh.co, you go to NABH website, all the standards are available for free download. So you can download all these books if you want. If you want a printed copy, you have to pay and then it comes by post. Next thing would be some resources where you could refer to when if you want starting. So you go to the website here, and once you're going to website, you click on this accreditation button here, accreditation radio button. You're going to go down, you're going to find eye care organization here. And if you're going to go onto this page, something like this will open, which will give you all the basic information regarding eye care standards. So where to start, don't ask your colleagues and friends, go there, read, it will take 15-20 minutes. The basic resources are all mentioned here. All your initial doubts and queries are here on this page. In case you are not going for eye care and you are going for entry level, that will come under certification tab. You go here, come down, you'll find this entry level certification program page. And here you'll get all the information which is related to this. Okay, so if you'll go there, you'll find all documents. All this information is what basically you can orient yourself and start before you start talking to other people, start talking to consultants in particular, because they will hide many of this pertinent information from you in the beginning and reveal it only in the end. If you go into that link here in accreditation to HCO, the blue book which I was talking to you, there it has also got details of surveillance and how the assessment process will take place. So this is how assessment will happen. You can go there and really get a first-hand information that what exactly is going to happen and how it works. In addition to that, a biggest thing would be your OT, because OT is one key area for us in ophthalmology. So you have to go there in the resources tab here, and you'll get this too. You'll get the guidelines for OT, and you'll get some information on the fire NOC requirements, which are these two are the key things which everyone will have question. And you have this information, this is what will be current, and this is what will be applicable to any kind of assessment. Next thing is, if you are going to the further step, please refer to AIOS CME series. Dr. Nirmal is the editor for this, and most of the common discussion points are there in chapters, and it has all the information which can really help you in ophthalmology. So this CME series is focusing more on ophthalmology, not on other specialties. So that's why it will be a key resource for you. All of us have contributed to the book. You can download it freely from AIOS website. So these are the chapters here, and you will find these chapters useful if you are planning or if you are even having NABH. You can see this and improve upon your system and processes. Most one of them in NABH would be importance on hand hygiene. And the best way to get hand hygiene thing is you go to the WHO website, type WHO guidelines on hand hygiene, you'll get this page, which will have all the information how to implement this in your hospital, including videos. And we have something called a safe surgery checklist, because NABH places patient safety at a very at a beginning. So for WHO safe surgery checklist is what we NABH recommends. You will get this kind of a page, and we have all publication in Tamil Nadu Journal and other journals where this checklist is slightly modified for ophthalmology, like IOL will come, A-scan and all things will get added. And this checklist is what we use for each and every patient. You can modify this checklist and then use it in all files. This is a mandatory requirement. And you will also have videos here which your staff can go through to see how do we do a timeout and implement this checklist. We also need to have a list for high-risk medication. A common question would be, what are high-risk medication? You go to ISMP list. You get an entire list of high-risk medication. Out of this list, whatever medications are in use in your hospital, you will select those. Because when I say here, the next time you download the entire list and put in the hospital that this is a list of high risk. No, out of this list, whatever we are having in hospital, that list we have to display, and that is what we use in different areas to have an alert for high-risk medication. Then there is also a very important thing you will have heard, LASA, look-alike, sound-alike medication. So a simple example will be if you use dilating drops, whatever, let's say Tropicacil and Tropicacil Plus. Both of them, if you see, they look alike. Only the cap color is different. The bottle is the same, name is same, very easy to mix. So that's where, if you are having look-alike and sound-alike drugs, you have to identify them and not to store together. And I am very sure if you are using these two medications in your OPD, all of us would agree that many a times our staff would have mixed. You tell them to put T-plane, they will go and put Tropicacil Plus. You tell them to put Tropicacil Plus, they'll go and put Tropicacil plane. So that kind of mistake happens. And to prevent those mistakes, we need to have this policy of look-alike, sound-alike drug. This also list is available. You can Google, or at least in our eye drops, it's quite similar. Each company, all their medications look clone of each other. Other thing is, if you are delving further, CAHO website is there. CAHO is a consortium of accredited hospital. In this, if you'll go, there's a resource column again. They have good stuff here to understand and read. In addition to that, you can also refer to AIOS website. All of us have, had this AIOS talks in meetings and all, which are uploaded. There also you'll find very good talks already uploaded for you to see. And it's not only that India has NABH. Worldwide, other countries also have their systems and they have their website. And if you go there, you will also find certain things which you can incorporate in your practice with or without NABH. They have certain good, interesting things which you can take down and use. And especially the UK website has got lots of other things also. So these are good websites to access and overall improve our practice. So other thing would be the process of any accreditation for eye care standard or even online. The process is totally online now. So you will have to go to the website which I showed, log in, create your account, pay the fees and go through the process. I just skipped that, but your NABH process is online and you have to keep your login ID and password credentials with you because that is what is going to be used for communication, everything. So whenever you are implementing, make sure that you are having the login ID and password of your application, because all of us have incidents where the staff who was handling suddenly leaves and is not willing to share. Then you have to go to NABH and give it back to me or whatever. So whosoever is handling your NABH account, please make sure that you have the login ID and password for your account. So these certain things were why we had eye care standards. So just briefing you on that. So eye care standard is a brainchild of AIOS. AIOS spoke to NABH and they wanted the standards which are specific to eye because we don't have daycare standards, whereas our 90% of work is daycare. So as a start, to get that ophthalmology focus, we have only specialty centered eye standard, which is eye care. Other specialties have also approached, but NABH has said no. So we are lucky in that way that we have a standard, specific eye care standard, which really comply to our kind of working much more. And this was a team led by Dr. Nirmal. So 5 members from NABH and 5 members from AIOS. So this 10-member group drafted these standards. That's just to give you a historical perspective. There's a team, and Dr. Nirmal would be somewhere there. Okay, so some of the reasons why eye care standards were there, Dr. Sean will cover in the last talk, so please be here, you can connect the dot there. He'll just speak about certain areas where eye care standards are more suited to us. And this is the last slide. What do we gain out of accreditation? Anyone would like to answer from audience? Yes. So money is the biggest motivator. Insurance empanelment and extra payment from CGHS and all is the thing. The only problem in that is when hospital go in for accreditation just because of these purposes, they don't sustain. So many hospitals will just push initially, get their accreditation, and after 2 years when the time comes for renewals and surveillance accreditation, the process has not been set in place and we found it lacking. So in case that's the primary motive also for us that we are going in for empanelments, insurance, extra money, but still we'll have to maintain the process to have that going on. Otherwise, after the first assessment, things start going south. Right. So other accreditation benefits which probably you may or may not agree, or sometimes, actually I used to fight a lot when they started NABH in our hospital with people, what the hell, and you're making us do extra work and everything. But later on, I do realize that some benefits are there which we may not realize in the beginning, but they start occurring to us 2-3 years down the line. So one of the important things is their definite overall quality improvement. And to get an idea, leave ophthalmology, go to any NABH accredited hospital for any other specialty and just see a non-accredited hospital, you yourself will find difference how the system functions. It's a well-oiled machine because all the parameters are put in place. Definitely enhances patient safety because we have all the things in place. I told we will have emergency facility, you will have your code blues, you will have patient care parameters being checked, and also you will have more patient safety. It is also a good branding and marketing exercise. All the hospitals probably display the logo. We are NABH accredited, first in Kochi, first in Kerala, or whatever way it is. And helps in risk management. We have not discussed here, but there is a chapter where we are going to talk about identifying risk and how do we manage risk and reduce risk. It also places a very big important stress on your medical record. And that is something which I realized later, because when we have medical record, it's not me alone. The duty doctor would have put notes, a nurse would have put notes, other consultant would have put notes. So if a patient is there, the file ultimately has many people involved in it. And then you get a court case after 5-6 years, come and give an expert evidence, it's an MLC case or something. So you will realize that whatever I have put is fine, but otherwise the file is all haywire. And we can't work 24 hours. So that thing is what the medical legal risk, the last slide, that completion of file, now I know because of NABH, everyone is going to maintain the file properly. Other people would have also put notes properly. So if I get a court notice and if I have to submit file, it is much better shape. It's a complete file. You tell me you need to get the file tomorrow, we'll give you tomorrow. So there is no need even for us to review the file. So that improvement in medical record is good, and all the consent will be placed and all, which I realized later when, after 2-3 years, I realized, yeah, I was maintaining medical record because all of us feel we are doing the job, but others are not. But definitely there are many misses. And some cost efficiency. So our stores and all, OT, there are lots of wastages happening, which we probably sometimes don't pick up. At least with NABH in our pharmacy, stores and OT, the consumable part, we did find that there is a lots of efficiency which has come in and lots of wastage is getting saved. Thank you. Thank you for your kind attention. Questions? Dr. Sean will take the questions with his talk. So we'll have a panel discussion question in the last talk together. So you can hold on, we'll all be here. So next we have Dr. Nirmal talking to us about OT design and infrastructure requirement for NABH. That's something which I believe is very, very useful. And I first time learned all about OT design from his talk many, many years back. So over to Dr. Nirmal.
Thank you, Gagan, for having me here, and thank AOS for the wonderful opportunity. So my topic is on the licenses, infrastructure and OT requirement for accreditations. So these are my disclosure, work as a I've been with NABH as a AC committee member and principal assessor, the honorary capacity. As Gagan said, we are passionate about improving the quality of eye care services in our country. And so this is the triad of quality of care, the structure in which we deliver the care. So it all includes the resources, the place, the staff, and the entire organizational structure. Process is how the care is provided, what exactly is done to the patient, and are the standards respected. And outcome is basically, we think in terms of visual outcome, but actually what patient thinks is his experience right from registration to the discharge process and also follow-up care. So this is where our perception differs. So good structure, as we all know, increases likelihood of good processes, and good process increases likelihood of good outcome. So this is basically on which this triad is the base of entire accreditation structure. So most of the early questions around accreditation or even the HOPE module is, what are licenses should we have? And that's the most difficult and common pain points for the accredited as well as hospitals going for accreditation. So one we have to understand is NABH has not put in all this licensing requirement, right? Very often they blame NABH for all this licensing issues, but actually these are existing rules, regulatory requirement for a hospital. So when you build a hospital, you have to build the structure as per the National Building Code. This was evolved 120 years back. It's not new, right? Only when the hospital industry started picking up and the infrastructure requirements were regulated, the new National Building Code came. That was promulgated in 2016. So it's been existing right from 1937. Then every 20 years it has been revised. So basically hospitals would come under Group C1. So where these are coming under the public safety buildings. So since we deal with a lot of patients, their attendants, their staff, so a lot of human traffic involved in the hospital. So we need to have a common infrastructure, like corridors have to be wide enough to take a stretcher in and stretcher out. So you need to have the doors with door width 2 meters, which means you have to evacuate an immobile patient through that door without any help or without shifting the patient. Same way, staircase width 6.6 feet. So that's basically stretcher turning radius. So and most of the fire exit doors should be fire resistant, so ensure patient safety. So this is basically National Building Code. You have to build the hospital as per this National Building Code. Your architect will help with this requirement. The next is the infection control system. So you need to have a heating, ventilation and air conditioning system. We all know how we suffer in Kochi because of the hot, humid climate. Basically in hospitals, there is an added element called infection control. So in hot, humid conditions, some bacteria, some molds grow, so which should not happen. That actually increases the risk of hospital-acquired infection. So you need to add to the infrastructure infection control monitoring also. And again, for patient comfort, there should not be any noise or vibration. The air conditioning system should be safe. And also from the promoter's point of view, there should be energy conservation while installing and commissioning. So all these are covered under the National Building Code, Section 8. So the next regulation was recently adopted by many states. Since health is a state subject, it has come under the Clinical Establishment Act. All the hospitals have to have registration under the Clinical Establishment Act. So this is what NABH standard expect, a mechanism to regularly update licenses, registration and certifications. So this is the standard format we suggest. So name of the license, valid from this date to this date. Some licenses are lifetime, some licenses are valid for only 1 year. So accordingly, we have to ensure there is a system for renewal on a timely basis. Right. So what we did together during the drafting of ICARE standard is, since ICARE institutions are very small and with focused scope of services, we reduce the requirement for unlike a general hospital. So the CEA, of course, mandatory. Fire NOC, if there is no fire NOC, at least a third-party audit for patient safety that fire systems are installed in that building has to be there. Then the Pollution Control Board, which is again a central act, which is mandatory. So if your biomedical wastage is mandatory, and if you are using a genset, you need to have a Pollution Control Board license. And if you are having a pharmacy, you need to have a retail license under the Drug and Cosmetic Act. So if it is outsourced, ensure the license is in that outsourced people name. If you are using narcotic drug, you might need to have narcotic drugs. Most of the eye hospitals may not have this. And if there is a cornea transplantation under the scope of services, you need to have a state registration under the HOTA Act. So these are essential licenses to go in for accreditation. Right. So there are certain other specific licensing or regulatory requirement. As I said earlier, you need to get a building permission and space allocation as per National Building Code. And then safe and hazard-free environment, so which again is very basic: fire NOC, PCB clearance, and biomedical wastage. And conduct of doctors, so it's morally binding on us. So the law of tort is one law that will have repercussions on when we go beyond the call of ethics and moral duty. So now it is NMC. Previously it was Medical Council of India. This is both for nurses as well as doctors. So I already told you about the importance of biomedical wastage. And right of the patient, again, consent is implied consent or express consent or qualified consent. It has to be informed consent. So this is under the RTI, it is obligatory on us to provide all the information if the patient demands within a particular time frame. You also have to share the records with the patients. And then the security of patients, particularly we have vulnerable patients, the pediatric age group as well as geriatric age group. We have to ensure that we take care of their safety. If you are dealing with a lot of pediatric patients, we need to have a system called Code Pink. So that is for child abuse as well as kidnapping. And under vicarious liability, the hospital administration is accountable and punishable if there is a deviation on this. Right. I think I've already told you about the Drug and Cosmetic Act and the NDPS Act. And the next one is the HR management. So if you have more than 10 people in your institution, you need to have ESI registration. More than 20 people, you need to have Provident Fund. And of course, the other requirements like Professional Tax, Gratuity, Minimum Wages Act have to follow as per the state norms. Right. So how does accreditation help in reducing medico-legal challenges? Good infrastructure is directly proportional to safe care. So that's where licenses help us to avoid all these legal issues. And good process, of course, documentation, soft skills and communication skills are very important. Licenses in place ensure safety, and structure and process gives good outcomes. So GAGAN asked to speak about the infrastructure requirement for operation theatres. I'll just highlight because it's a long topic, but now this zoning has also come under the licensing norm. So previously it was only part of the accreditation standard, but now, so this is the Tamil Nadu Government Gazette. You can see that operation theatre space, zoning, equipment, staff, record keeping are all placed under this regulatory act, Clinical Establishment Act. So this is the directly from the Clinical Establishment Act draft. So you need to have minimum 160 square feet for providing critical care in the operation theatre. For eye care, this is the basic minimum space requirement. Added to that, you need to have at least 30% more space for the support structures. Right. And if you are having a critical area like operation theatre, it is mandatory. We have admission and discharge register, infectious register and medical legal register in our hospital. Ensure all the systems are there. NABH standards may not prescribe this, but since this is part of licensing requirement, the hospital has to maintain all those things. And as I said, I can see that we come under the center, daycare center. Even most of our hospitals are daycare centers, so it is covered under the Center Act. It's not clinic or not hospital. Right. So this is the directly copied from the Clinical Establishment Act. So as I said earlier, 10.5 square meter. So in addition, circulation space of 30%. So what does the standard says? So basically it comes under these two chapters: hospital infection control and facility management and safety. So just briefly give you the overview in the next 2 minutes. Intent is to provide safe and secure environment for our patients as well as staff, and to handle any emergencies within the OT. And there should be a program of support service for the equipment and management. And this is another useful resource which me and Kumaran has written: operation theatres and sterilization requirement, design, consideration and standards for infection control. It was published in our TNOA journal. So it has been downloaded about 65,000 times now. So how to plan? The first requirement is we should not do any harm to the patients. So basically in eye hospital, the problem is the small structures. So it adds to the complexity, because in theater we have to ensure that the design incorporates three different functions. One is it should be a safe, comfortable and calming space for the patients. Some patients develop claustrophobia when we have a dark small space. So, and also it's difficult for the care providers to navigate, particularly in space difficult areas like Mumbai. We have to navigate the space during surgery. That's important. We also need space for our huge machinery. And third important aspect is infection control. So we need to provide zoning for the equipments, ventilation and unidirectional flow. So in small OT areas, incorporating all these elements is difficult, and that is where the complexity and difficulty for eye care hospitals. So there are softwares now available to calculate the space and requirement for operation theatre. I will not go into the details. So if you are going to upgrade or modify, please consult architect who are experienced in hospital designing and also NABH standard. So that will be easy and useful for the owners. So basically in operation theatre, it's not only the space, you also have to consider patient safety and infection control. That is a prime aim. You also deal with a lot of medications, so there has to be space for storing the medications. Equipment management is important. You also have to train your staff. But mainly when you are designing a theatre, ensure you take care of the long-term and short-term goals. So, and also how we utilize this. This is one area where we'll be utilizing on a daily basis. So you have to optimize the patient requirement as well as space requirement. So as I said earlier, 4 well-defined zone is important, and ideal design is that green area is sterile area, then the support areas have to be semi-sterile, and then we have the administrative areas or the entry zones, and then finally the disposal corridor where the infected or soiled linen instruments are all taken care of, washed and reused or disposed. So basically you have to divide the space, cleaning, disinfection, sterilization area, but ensure this important principle, unidirectional flow, is followed up. So OT walls, these are some of the oft repeated questions. So you can have any type of wall, but ensure that is easy to maintain and it is clean without any much of joints or sealing requirement. So dust proof, moisture proof, corners ideally it should be coved to prevent dusting and facilitate cleaning. Door should be 2-leaf, and ensure that there is some natural or general lighting coming up, because we will be working in a dark environment. So if there is a space to see outside, it's good for our eyes as well as body. Then modular door, you can use stainless steel, but ensure it is medical grade, because we'll be using a lot of chemicals. So most often we see over a period of time there is a lot of corrosion as well as dent in the steel. Ensure the vendor uses good quality steel. If at all you bargain for the best. So the flooring, you can use the epoxy or vinyl flooring. So ensure that thickness is 3 mm and it is properly leveled, because epoxy generally over a period of 5 or 6 years, it can get damaged. And ensure you have a good surgical scrub area, whether sensor or knee operated. So over a period of time, it reduces strain on the surgeons and the team. So if you are not able to do proper zoning, this pass box can come to your rescue. It has multiple uses. It also has a UV germicidal lamp where you can store the items for some time. And I will not go into the details of the air conditioning requirement, but generally the split ACs and window ACs are not recommended, because it's basically a recirculation unit, and there are pockets for microbial growths or molds formation inside these air conditioning units. So if you are using any air conditioning unit, whether a split or the AHU system, ensure there is good engineering control. More than the installation, maintenance is very important for these structures. You have to ensure the AC ducts and filters are cleaned properly, filters are replaced properly, and also ensure there is no seepage in the plumbing lines. So infrastructure requirement for the OT as well as hospital is a legal requirement, and standards focus on patient safety and how you effectively use that space. Then it is important to reduce medical and surgical errors, and good infection control is important. It should be comfortable for all patients, staff and doctors, And over a period of time, maintenance takes a lot of costing. So you ensure that you install easy maintainable and cheap substances, and it also saves you from medical legal cases. So a well-designed planned OT will really help not only in accreditation but also efficient management of your practice. So the time is always right to do what is right. Compliance with licensing norms, regulatory requirement is not just a legal obligation. It is a moral responsibility towards our patients and hospital. Thank you so much for your kind attention, and thanks for the opportunity.
We'll take questions in the end, sir. Important announcement, if anyone has questions, you can write on paper and give it to Sean. In his talk, he will take all the audience questions, and that's a panel discussion also. Yeah, please take it. So next we have Dr. Kumran, again continuing the theme of OT and talking about OT sterilization and other infection control practices in OT. He has a very nice video for that, and I think so he'll wake us up from our slumber. Probably he'll crank up the sound also, all the drums and beats.
So good afternoon and a warm welcome to one and all. At the outset, where I would like to thank Dr. Gagan, Dr. Nirmal, and AIOC for this wonderful opportunity. So my topic is on hospital infection control. As you would know, hospital infection control is a very vast topic, and putting them all together in 20 minutes is going to be very difficult. So I'm going to highlight only the most important or the salient features for you to take home. So I have my presentation in two formats, a slides and a video. I'm not going to play the slides for the obvious reason, as Gagan said. So I will play the video so that it could be more interesting, and I will take the questions after it gets finished. Please. So hospital infection control doesn't start only with infection control inside your operation theater, but it also involves right from the time you enter your hospital to the disposal of all the biomedical waste. The most important is the simple hand wash. It's always good for your hospital to have a dedicated restroom and a separate room for your staff to wash your hands and feet before entering into the theater. And once you enter in the theater, shift to your scrubs. And if your hands are clean, it is enough to use your hand rub. But if they are soiled, you have to follow the surgical hand wash. The surgical hand wash, as you all know, the three things, above elbow, below elbow, and your wrist, with each one lasting for 30 to 40 seconds. The other important point I would like to note here is the water. The water is one of the important components of your hospital infection control, because in every process you use them. So it's always good to use a purified water, either RO or distilled water, according to the availability in your particular institute. And ensure hand wash is done properly, because it's very important. And once you do this, you enter your theater. Make sure your theater has all the physical parameters are properly monitored. Use your aldehyde-free, alcohol-based disinfectant to wipe all the surface of your medical equipment, including your Mayo table. Use a lint-free cloth and ensure the same part of the cloth is not used to wipe repeatedly. Once this is done, your hospital assistant then shifts all the sterile goods directly into your OT. And if you're able to keep your autoclave or the CSCD area open directly into the sterile area, it makes very nice. After the hand wash, the hospital assistant then dons all the PPDs as per necessary and uses alcohol-based disinfectants as when needed. Then you prepare the Mayo table using the two-step technique, where a linen followed by a plastic. This is basically to ensure that in case you miss some products on the table, they don't reach the surface. The most important, check all your indicators starting from class 1, 5, 6, and also a biological indicator. Teach your staff how to identify failures, because most of the time they don't look into it. And a failed indicator, your surgery you finish and then you see the indicator has failed. The class 5 indicator, which I'll be talking about later, is most important. There are 2 vials, which I'll be talking about later. If you're following the bundle, ensure the no-touch technique is followed for the bundles, where the inner bundle remains sterile. And once this bundle is removed, ensure that this bundle also carries the Bovidic test or the class 2 to ensure that the bundles are also safe. And this is a view of the operation theater, which is ready for surgery, and make sure there are space all around for the patients and the emergency equipments to move across. So once your theater is over, the instrument processing, a unidirectional flow of instrument is very essential. All the used instruments along with the biomedical waste used for this particular case has to leave the theater immediately. These instruments is a good practice to collect them separately and not handle them directly. These instruments are rinsed under running tap water, preferably a RO or a distilled water. This is to ensure that this removes all the dried blood and body fluids on the instrument. These instruments are then processed in an ultrasonic cleaner. InstruClean can be added, and preferably warm water is used. Once this is processed, all the instruments are then again rinsed using the 3-bin technique. They are sequentially rubbed with a fine bristle brush to ensure that all the blood and body fluids are removed. Teach your staff to not to hurt themselves and the instruments, because because sharp instruments can get blunt. And also ensure, if you're using a chemical disinfectant or an InstruClean, ensure that you remove all the residues on the instruments to prevent TARS. And once this is done, make sure to use a high flow agar to get the moisture out of these instruments, because if you're autoclaving these instruments, and any residual matter could hamper the sterilization process. Using a high flow gun is very important, but ensure you also fit in a filter like this with a nano filter, which makes the air purified, and this would help you to disinfect and remove the moisture from hollow tubings as shown here. So this is very useful if you're reprocessing your instruments immediately, not allowing adequate time for them to get air dried. So here you could see how the moisture is being let out of the phaco tubings immediately using the air gun. So knowing about the autoclave, we know all about the autoclave, but you have to know a little bit more about the autoclaves, because that would help you to troubleshoot whenever you have a problem. The simple principle is water boils when the vapor pressure is equal to the atmospheric pressure. So increase the pressure inside the autoclave, so water boils more. This is a very simple technique. So autoclaves are based on 3 principles, based on the fact how they're able to remove the air inside. The vertical autoclave, gravity-based air displacement, and the other autoclave where you have a pre-vacuum and a post-vacuum cycle. And the Class B autoclave, we have multiple pulses to remove the air inside. And for ophthalmic use, when you use hollow instrument, the Class N or the Class B autoclave works well. So the autoclave, basically whatever autoclave it is, it has 2 jackets, an inner jacket and an outer jacket with a series of valves. These valves let in the steam inside the autoclave in a graded manner for the temperature to raise and sterilize your instruments. Most of the time, these valves are the one which causes the leak, which causes a failure of the sterilization cycle. So you really need to know these valves, how they function, change the gasket or whatever is possible to ensure that they work well. So this is a simple working model of how the autoclave works. The steam is then lit, made to enter the inner jacket, wait for it to reach 121 degrees Celsius at 15 psi for 21 minutes, the sterile cycle, and then the drying cycle is altered. So you have to teach your paramedical staff of all these parameters of time, temperature, and pressure. These are the disadvantages and the advantages of a traditional vertical autoclave. So you just add on a vacuum pump to your traditional autoclave where you have the pre-vacuum and the post-vacuum cycle. This is able to remove the air inside the autoclave, create a perfect vacuum, and hence the steam is able to penetrate all the areas and have an adequate sterilization process. When you have a multiple cycles of the steam and vacuum, is simply called the Class B autoclave. A single cycle is called the Class N autoclave. It's quicker, keeps the load dry. The most disadvantages is expensive. So now you have sterilized your instruments, and now we need to validate what we do. Validation, monitoring, and verification goes hand in hand. So you have hand dried the instruments after washing them. They should be packed as shown here. A Class 1 indicator is stuck outside. We use the plastic paper pouches for every individual case, and this instrument set having a Class 5 integrator inside each set is placed here. And use a medical grade sealant is very important, which goes around 3 inches sealant is here. And the other most important thing I would like to tell you is the way these instruments are placed inside the autoclave. Vertical placement has been proved to ensure that the steam is able to penetrate inside. The most important validating technique, the biological indicator, same vial, same number, 2 vials, one is kept outside as a control, the other is packed exactly the same way you place your instruments. And this one is placed along with your instruments and goes into the autoclave, whether it's a linen or your instruments. The Bovidic test, as I told you, is not useful for the vertical gravity-based autoclave, but you're using your class N or your a class B autoclave. The Bovidic test is placed inside stacks of linen. You can place as much ever stacks of linen you want. They are wrapped. And the most important thing, it should be processed only inside an empty autoclave and not inside a fully packed autoclave, and place them in the most demanding part of the autoclave, which is usually the exit or the entry. Run the cycle. You need not run the warm-up, the dry cycle. Once the sterile cycle is over, the autoclave can be put off. Then you remove the stack and ensure that the Bovidic test has changed changed color. Once this is done, now your autoclave is ready to be packed. And ensure the Bovidic test should not be done along with your other instruments. This tells you the troubleshooting of a failed Bovidic test. The common things are air leak, unwanted condensation, faulty pack. Sometimes a warm-up cycle is needed in certain autoclaves, and an incorrect procedure. You need to educate your staff of what has to be done in the event of a failure. The class 6 works well when you're doing hollow instruments. This basically ensures your steam is removed from the hollow tubings. It consists of a 1 meter long tube with a 0.1 millimeter lumen with a case at one end. The way you fold your strip is very important. Fold it inwards and not outwards. And then it is placed inside this casing, which is then fixed to the tube. This is simply based on the principle that your autoclave should be efficient enough to remove the air first, and then has the adequate pressure to push the steam inside this series of tube to reach the indicator on the other side. Again, pack it exactly the same way as you pack your phaco set and the other instruments. And then place it exactly the same way you place your instrument. So you're actually simulating exactly the same demanding technique for your instruments also. And then it is packed inside an autoclave. We have a horizontal autoclave. The advantage of a horizontal double door autoclave is that one end opens into the CSSD area, the other opens into a sterile area. So you need not take all your instruments from an unsterile to a sterile area again. The parameters, there are 2 parameters, 121 degrees Celsius, and another one is 134, which is used for the flash sterilization process, but not to be used as a routine sterilization. This is a troubleshoot for your helix test. Based on the color change, you can see what has gone wrong. So if you're using porous loads, use the Bovidic, or a hollow instrument and both porous, use the helix PCD test. It's called the process challenge device. So your autoclaving is now over. You have to really look into all the indicators that they have changed color. And the most important one, as I told you earlier, is the biological indicator. Nowadays, you have devices which can read the biological indicator in 10 minutes. This is a perfect look of a class 5 integrator where the chemical has traversed the entire window. This is a troubleshooting of a class 5 integrator. Whenever the integrator has changed color more than 50%, the load is sterile. The biological indicator, as I told you, has 2 vials. One is kept outside and the other is kept inside. You remove the processed vial, and you have to break the inner vial, which contains the broth and the indicator. Please place them only after breaking it, otherwise you would find all remains violet. So this makes the broth and the bacteria, which is Bacillus thermophilus, which is the most heat-resistant bacillus, incubated at 57 degrees Celsius for 2 days. Most of the time, you will read the result in 12 to 16 hours itself. The maximum has to be incubated for 48 hours. This is unprocessed vial. The bacteria has grown. The vial has changed yellow in color. This is a processed vial. The bacteria is killed, so it remains violet. Sometimes you can also process these vials in a third-party NABH or NABL accredited lab to ensure that your incubator is working well. So whatever you do has to be documented, right from what is the load has to be sterilized, what are the contents of the load, what are the indicators, everything has to be recorded as shown here. So next, finally, we have done the surgery, and now we have to clean your theater. Biomedical waste norms are very stringent, so ensure that all the biomedical waste are segregated at source, and they also have a unidirectional flow leading on from the sterile area directly into the disposal zone. So this is here, you see all these biomedical waste are segregated at source. They leave the operation theater immediately, including the linen if you're going to use them. Handling of sharps is very important. Never recap your sharps. They have to be destroyed as shown here. Do not burn them as used to be done earlier. The hub is also destroyed. So the main aim of showing this video is that do not recap them, because recap leads to injuries. Measure the biomedical waste and note them in a separate register. And whenever the biomedical waste is being taken out, it is very important for you to get a sign from the person who's collecting the biomedical waste, because this is very important as a legal indication also. So all the biomedical waste is disposed. Now you have to clean your operation theater. We again follow the 3-bucket technique: clear, RO, water, and we mix the disinfectant in the final bucket. Use a clean and a dry mop. Sequentially immerse them as here. Make sure it is dry and not dripping. And then finally use the most time-tested figure 8 way of mopping. This basically ensures that no blind spot is left out and all the areas are well cleaned. The walls, you do not clean the roof on a regular basis, but you have to use a lint-free cloth and use the 3-bucket technique again as shown before, and clean up till probably 5 to 6 feet or however tall your assistant may be. The roofs can be cleaned once in a month or depending upon the protocol you follow in your hospital, and also depends upon your volume of your surgeries. Making the edges of your hospital theater combed as shown here could avoid a lot of problem for your cleaning staff, because dust would not accumulate. This video I've already shown you. I told you earlier, use a lint-free cloth and clean all your medical equipments, including your tables, once before you start and after you finish your theater. Biomedical waste norms of water disposal are usually neglected in most of the centers. All the biomedical waste from your hospital, the water especially, has to be collected in a separate integrated chamber, disinfected with your sodium hypochlorite solution, allowed to stand for 30 minutes before it is let into the main sewer. So after 30 minutes, there's an intermediary chamber which opens up and the disinfected water joins a normal public source. And finally, there's a short note on your HVAC system. As Dr. Nirmal told you clearly, the HVAC system is an engineering control. If you are going to install a HVAC system, you need to know the basic parts of it. There are 3 parts: the compressor, the AHU, and the terminal air filter. It's very important for you to know all these things, because otherwise during your AMC or your CMC, they would not clean these areas properly. So they have, and the return air ducts has been installed 70 to 150 millimeters above the floor level. HVAC simply means heating, ventilation, and cooling. And the main aim of this is to control the airborne particles, maintain the room pressure, moisture, and the temperature. As for now, this is the only way which you can regulate it. It converts a turbulent airflow into unidirectional airflow. The parameters inside the HVAC system or inside your theater depends upon your volume of your theater and what kind of surgeries you want to perform. Of course, a transplant theater has different norms than an ophthalmic theater. So these are the settings which we have. And this is the flow chart of the airflow. This contains 2 sets of filters, a 10-micron filter, a blower, and a 3-micron filter, which then finally leads on to a 10-micron filter, which is placed inside your theater. The physical parameters of the theater has to be monitored frequently to ensure that the negative pressure is maintained. The most important thing I want to tell here is that the head and neck of the patient has to be placed right under the hood of the HEPA filter. This particularly tells you the force which the air is sucked out of the operation theatre. So all the flowing particles are taken away from the main sterile zone into the ducts. And they have to be monitored, filter integrity test, temperature, particulate count has to be monitored regularly depending upon your volume. And finally, technological advances happen. Instead of monitoring them physically, you can also have an Android or a Google-based system where the OT parameters comes to your phone immediately 24/7. And finally, this is the last minute of my video. These are the different frequencies, how you have to clean your theatre. This is very important because you really have to monitor how your HVAC system is cleaned. Remember, your 10 micron filter can be water washed because these pores accumulate a lot of filters. You should not air wash your 10 micron filter. You have to water wash your 10 micron filter. The 3 micron filter should not be water washed. It has to be air washed because if you water wash, the 3 micron filter is damaged. And then the air compressor also has to be cleaned with the water. And your HEPA filter, your terminal HEPA filter should never be cleaned. It can only be changed. And you also know what a HVAC system cannot do because the edges are always not sterile. So a HVAC system is no alternative to proper cleaning. So HVAC is an engineering control that gives us clean, filtered air and mercury-free as for now, safe for both you and your patients. Thank you.
Thank you, Doctor. We have question from Dr. Bhuptan from Surat. Sir, can you please ask your question? Dr. Shakeen Singh, in the meantime, can get ready with his presentation. He's telling us about the accreditation process, how we can make it smooth for us, and at a hospital level, how we should, plan for it. But sir can ask question first.
You are discussing it for ECU, but when there's a small entrepreneur with a small hospital, being applying for entry level, what I believe is that a split air conditioner is allowed in an entry level operation theatre. Second thing is in the zoning part, the door, according to the OT consultant, he said that if it is 3 feet, then a single lift door will be okay. We don't need a 2 lift door. Right? And other thing is that in the unidirectional flow, when the sterile equipments are taken from the main door inside the operation theatre, and the unsterile material, can they pass through the magnetic pass box to the biomedical waste corridor built outside the operation theatre? So that is how.
So let me answer your first question, first part. See, entry level is basically through the app system called Hope Portal, right? It is self-explanatory and easy for all type of people. So administrators or even the doctors can use it. It's basically filling up application form, informing the accreditation body about your infrastructure, manpower, the equipment you have, and what are the support services you have to fulfill the norms required for that particular scope of service. Suppose it's only eye care, anti-segment or cataract surgery, glaucoma, the basic eye care services, you can limit your requirements to that. So accordingly, the licensing requirement also will vary. If you're not providing cornea services, we will not ask you about the otor transplantation. So it's as per the scope of services. So you can choose your scope of services and accordingly have the right infrastructure to provide that services. Okay, I think I've answered your first part. The second part is whether split AC is allowed. So as per accreditation norms, split AC, since we told you that there are certain difficulties with reference to maintaining the infection control system. So there's basically recirculation units and it's not, it actually compromises the infection control. So for entry level at present, we are giving an exemption, provided your process should be stringent enough to take care of the cleaning of the filter, changing of the filter, and regular monitoring of the microbiological activity and trends in the infection control rate. So if the infrastructure is not up to the mark, Your process should control that mechanism.
So on how much duration should be measuring the microbial part of the operation theatre, the split AC filters and all that? Is that
No,
the criteria
it
that
depends on the volume of your service, the size of your operation theatre, the type of surgeries you do,
Yeah.
whether it's a lot of septic cases or only clean cases,
So-
the number
suppose
of people entering and
Suppose I'm only purely a cataract surgeon and I outsource even the
that's what.
TCR stuff.
So,
So what I wanted to ask is that the equipments, basically the instruments are technically sterile even after the surgery. So is it possible for me to use an ultrasound bath in the operation theatre while cleaning the instruments and then take them out?
no.
for
So
the-
you have to define your own policy as per the requirement of the standards. So we will not know your infrastructure
Okay.
or the type of services you are providing. So at present, the Hope portal takes care of the entry level accreditation. So entry level is basic standards. A basic structure should be there. Your process should be stringent enough to not to compromise patient safety and infection control. If you think in that lines, it's easier. Need not go into the details whether single door. So even with single door, many hospitals have been given accreditation. Right. So only thing, there should be a mechanism of evacuation of patients during emergency.
Yeah, that is.
Okay.
I'm only worried about the zoning part. If you
No,
need a separate...
zoning you need not worry. All you need to understand the standards from the right perspective, from patient safety perspective, from infection control perspective. If you are able to satisfy those standards, well and
Thanks.
Over to Dr. Shakeen.
Thank you. Good afternoon, everybody. I must thank at the outset Dr. Gagan for giving me this opportunity to stand before you and the AIOS as well. So the topic given to me is how to prepare an ACE NABH assessment, important do's and don'ts during assessments. Basically, during any assessment, we have two people to visit us and everything to be prepared and to be displayed within 1.5 days. So those two person is going to take care, like the process is examining the documentation, all those legal SOPs, and then is the physical verification, visiting of each and every part of our hospital, the process, and they would go through from outside till the depth of the institution. So I would try to cover maximum possible, and there is an overlap also, like creating those instruments, then assessment of those instruments would be overlap, and I'll go stepwise. So the first of all, as has been told, what we need to do for the NABH assessment, is it we want to have the insurance or we want to add the quality? I believe if we want an NABH assessment or prepare for the NABH assessment, the first thing we must learn, we should have a quality issue with us to improve on the quality. So mindset to NABH accreditation, we are working for the quality. To procure NABH assessment book, as Dr. Gagan has already shared with you, to identify key person in your own institution, those going to look into this, identify core area where we need to work on, take all employees along, because everybody has to be involved into one or the other part of the working of the hospital, otherwise it's going to get us NC anywhere. And then you submit the application, reach NABH website, yourself search your own login and password so that it's procured with you only, and as and when you need, you can go into that. Do not be dependent upon third party, as most of the institutions they do it. Do not take someone else's SOPs, because most of the hospital we go, SOPs are belonging to somebody else and your institution is totally different. That's going to create a chaos. Do not let third party to control your password, login ID. Like you have to update your login ID and maybe it's you are in trouble in future. Do not use third party manpower, because usually they would give you for 3 or 4 or 5 days, and they are not concerned with your institution. They are not concerned with your quality of work. They just want for the assessment to be conducted in the way they wish to. Do not waste time during assessment. Most of the time, as I've told you, we have to go all across the areas within a limited time. So if we try to waste the time, it's going to compromise the assessment. Do not gift anything to visiting team. Focus is the patient safety, staff and employee safety, environment and community safety, information, education and communication, measurement of performance, what do we do, organizations around important functioning, and key person to start with this identification and responsibility to share with them is the MD CEO, overall responsible for everything. Then we have an NABH coordinator, quality manager, which is a key person, I should say, responsible for quality upliftment, identify, create SOPs as per SEO need, training of the staff, monitoring of the working, and then audits. ICN, infection control, awareness about prevention, hand hygiene, SSI, etc. Safety officer to facilitate facility safety aspect from all aspects to be a safe organization. MRD in charge for statisticians, pharmacist, responsibility, store in charge, and counselor for the smooth working and day-to-day working. Identify and document vision, mission, statement of the registration. Prepare SOP of your own. Identify core area, distribution of different responsibility to different person. So one person is responsible for a specific thing. Education and training of department leaders, like one person in the reception area, one person in the initial assessment, one person in the OT, one person in the medical record, one person in the HR, who is given a core responsibility to train their own person and monitor daily working. Identification and procurement of all related statutories towards law, regulations, formulation of committees with their heads, distribution of responsibility towards preparation and conduct of assessment, and core areas, scope of service, what actually scope we have in our practice. Maybe we are eye care organization, maybe we are not doing vitreoretina, maybe we are not doing oculoplasty. So exactly what we are doing is the scope you provide, and specifically to the pediatric care, what amount of pediatric care we are giving to give it, and that has to be displayed. Patient registration process and space for that. Patient care area, care of the patient, where you have to take the OPD, the procedure, all those areas specifically for those, lab and x-rays, investigations, whatever is related to that. Operation theater has been very well covered with Dr. Kumaran, and CSSD along with the theater, MRD and store and record. Key areas for the hospital infection control program, biomedical waste, facility management, facility rounds, which is a has to be specifically chart, fire safety measures, vulnerable patients and their care, emergency care, tries epidemics, during epidemics, patient right and responsibilities, management of medication, biomedical engineering services, mock drills, code blue, fire, child abduction, has to be aware, done, audited. Information technology, education training of all concerned staff members. It's our responsibility to train and educate all of them, then audit them towards their responsibilities. Audit and documentation of all above. Whatever we are doing, giving an education, we need a documentation, because that's going to give us our raw work, whether that's been done actually or it's been just created. Self-assessment toolkit. Farm committees, multiple disciplinary team for NABH implementation, quality committee, safety committee, infection control committee, pharmacy, and farm subcommittee in your own group. During assessment, this is what we need to look before we go in for the assessment, and during the assessments, go through the mailed guidelines toward assessment by the team. The team is going to give you guidelines. This is the process, this is the time, these are the assessors, this is the way we would go to. So reach to team for brief processes. All documents prepared, displayed, easily accessible by the assessors. Wherever you provide them a room, all those SOPs and documentation should be ready for their use. Whenever they want, you are easy to drag this out and give it to them. Entry-level online preparations, dedicated mobile. If it's an online, let's say for entry-level, you need to have a dedicated mobile with no incoming calls, with good quality camera, because it has to be documented there at the NABH. That's what is being photographed there. Area to be visited, well prepared, informed beforehand, so that we can save time. Office arrangement, adequate size with the following infrastructures: computer having USB and CD writer with the print facility and internet facility, because now we have to upload the online. Punching machine, stapler, highlighter, gum, tape, scissors, 2-3 writing pad and cardboard, because we have to go for the observation. The cardboard is going to help us for our own help. Ready with the mock drills. Anytime the assessor, they can ask you for the mock drills, which we are already prepared. Waste no time here. And in the opening meeting, to begin with, there would be an opening meeting. In opening meeting, all concerned, including leaders, quality person, all departments concerned, area heads should be there. We were going to share about hospital name, location, city, state, legal identity, registration authority, covered area, scope of services, number of beds, number of OT, number of surgery, number of consultant, doctors, nurses, different MOU which we have in the outside, legal compliance status with date, when it has been to be renewed, what it has been renewed, innovation and achievements of the organization. After the principal assessor address, documentation to be kept ready, scope of services which they need to carry along, copy of an updated summary list of licenses with the indemnity form, scope of opening, presentation and quality indicator, list of doctors, nurses, technical staff with the qualification, designation and state registration. During the facility round, that would start from the outside of our hospital, right from the display of your boards, display of a SCO name, original language, display of a scope of services, display of a consultant's name, display of vision, mission, display of patient right and responsibility, display of signages like fire, washroom, facility for vulnerable patients like ramp, wheelchairs, special sitting plan, special sitting washrooms. So once you are into a facility round, they are going to watch each and everything all around. Facility inspection about safety, fire hydrant, sprinklers, smoke detector, fire exit, fire safety instructions, exit plan.
Shakeen sir, these are running little short of time. If you can finish.
Okay. So I'll just run fast.
Slides and then Sean can finish.
Okay. So during this, they would go to the review process review, staff training observations, staff safe patient transport for area 1 to other, patient interview, staff interview, outsource staff interview, document check, scope of services, vision, mission, policy, self-assessment toolkit, Apex manual, training manuals, quality manuals, induction manual, patient safety manual, infection control manual, drug formulary, drug antibiotic policy, audits for internal, medical, clinical safety and prescriptions, committee meetings, then SOPs. We have our documentation for each and every, chapters, like for care, for assessment and continuity of care, we have a transfer in out, referral in out, initial assessment, time frame, TUT. Then related to the patient care is the uniform care policy, triage, emergency, code blue, vulnerable patient, discharge policy, restraint of patients, nutritional assessments. Towards medical management is the hospital formulary, purchase, safe storage, handling of medicine like LASA, emergency medicine, policy of verbal orders, high risk medicine, medicine recall, near expiry, safe administration, labeling, medicine error, adverse event, narcotics, policy for implantable prosthesis. Process is important for IOLs. Then for the patient right and responsibilities, basically the right and responsibility to this should be displayed there. Informed consent, list of procedures for consent, complaint and feedback from handling system. Towards infection control, it's been probably covered well. Infection control program has to be there. Surveillance, high risk areas, standard precautions, safe injection and inclusions, cleaning, disinfection and sterilization process, antibiotic policy, laundry, kitchens, housekeeping, sterilization process, biomedical waste, and then the related to quality program, indicator KPIs, patient safety program, audits, incident reporting, sentinel events, and document responsibility of the management, vision, mission, value of the organization, organogram, compliance of the regulatory law and licenses, scope of services, employee right and responsibilities, and facility management, facility rounds, up to date drawing, site layout, breakdown management, management of the safe water, electricity, medical gases, fire safety, hazardous material, identification of any risk. HR is the planning, job specification, recruitment, induction, appraisals, disciplinary grievances handling, credentialing of the people, documentation towards the IMS need of organization, MRD, confidentiality, safe storage, retention policy, destruction, and medical record review, privileging of entry. And that's going to work, see the work instructions like mopping, hand wash, biomedical waste, prevention of wrong side, procedure, etc., material safety. And all the external manuals, your MOU with the others, literature of the medical equipment we use, guideline for the current use, handling, storage, disposals, patient safety aspects, education, identification, audit for adverse event like sentinel event, medical error, fall, needle, stick injury, near miss. All this CAPA needs to be. In the medical record,
Sir,
usually
can we sum up, sir? We are
just
really getting late.
three lines.
Sir, we have only 7 minutes left for show.
Okay. So there are responsibility of the quality people, admin people. Biomedical waste has been well covered, and vulnerable patient, we need to have a wheelchair, ramp, trolley, washroom, assess. Infrastructure, all aspects on completion, online report submission is there, required good connectivity of the dedicated area. HIC quality presentation KPI are to be uploaded along so as to be ready with this. Team will share this observation before submission. Try not to justify or correct there only. You have enough time thereafter. Look out for your weak areas to focus on for next assessment. Correction worked upon again will go to a PA for closing. Submitted report will go to accreditation committee for final decision. The accreditation committee decision will be shared with you soon. Thank you.
Thank you, sir. Now Sean will take over the last thing. So he's basically talking on your behalf, the problems of hospital going for accreditation. We all are having our accreditation and we also face the audit. So we definitely identify with them, and he also take audience question along with that.
Open slide. Thank you, Dr. Gagan, and thank you for having me here, and to the AIOC Managing Committee. I'm on open kar lo na. Haan. So I think similar to what Dr. Gagan mentioned initially, I was part of Arvind Eye Hospital, Madurai, and getting into NABH was really painstaking, trying to see 50 patients a day and trying to write all the documentation. Overall, once you move into the process, I think what Dr. Nirmal also often emphasizes, I think the intent is very important. I encourage all those who have not gotten to the NABH journey to join this. And the initial process, there may be a huge lot of difficulties. Once you start going, I think you can complete the procedure. So some of the pain points which we have come across, and my senior assessors will be able to highlight much more, is certain areas which we will be going more into the details later on. But the first thing, as Dr. Nirmal said, is start with all your legal documents. Don't leave that incomplete. We have seen cases where the fire safety license has been applied for, and when you actually go for the assessment, it's not yet complete. We know the biggest time dependency is government offices, and it can be painstaking. So have all the legal work all ready, all your licenses appropriately. I've not mentioned here the HOTA license. And as Sir mentioned, depending on your scope of services, you may have other licenses also required. Again, infrastructure issues. If you have a lift, then lift license should also be there. Looking after vulnerable patients, and in certain areas when you actually go through the whole NABH process, you know that actually patient safety is getting a very high priority. I think prior to starting with NABH, even our GA station, we used to not even look at end-tidal carbon dioxide, but slowly they are getting into monitoring cases, because we know even in an off-TAM setup, and you're doing one GA case in a month, that one patient can land into severe consequences if we haven't done certain things in place. So I know that low volume setups, but I remember my medical college days, and as a resident, unfortunately, we had to be part of a morbidity meeting and all hell broke loose. So I think small points here and there, but try to close the ends as much as possible. Operation theatre, very important area, very beautiful presentations both by Dr. Nirmal and Sir. I think covering each and every area in detail, the importance of autoclaving, the importance of understanding that everything is important. Let's not argue about A class, B class autoclave. Having the entire process, are you monitoring your microbiological standards? Are you checking the validity of a process? And then are you trying to get better? Again, there are some issues here, and you have to have your own policy because we do reuse instruments, and having your own individual policy for reprocessing is perfectly fine, and having them as you ETO sterilize numbered as to how often you do the reprocessing is important. Your laundry and linen management, and again with the phaco tips, I think the cost versus what we can do best, how do we autoclave in between procedures, that is an important area. Again, as Dr. Gagan was also pointing out, is each state may have different requirements. There's no mandatory requirement. We may have started off with a small setup and the space may be small, but within that space, if we can improve and try to get better to the next level, I think that is the entire process going ahead. I mean, not any one of us over here would like just to have an NABH at the entry level, but we would like to go all the way. Manpower is a major issue, and in certain areas you have to have trained, qualified people, and having adequate people if you're running your own pharmacy, nursing. Doctors' experience and qualifications, especially if you're having scope of services covering subspecialty areas where they've been trained, what is their years of experience. IC and nurse, I think let us now slowly look into having them trained in facilities which are sometimes better. They learn a lot more. Many multi-specialty hospitals have training courses for a couple of days, and that's how you actually improve the entire manpower of the hospital in what they are learning and how they implement processes within the hospital. And even sending people for ACLS training, doctors, especially in the operation theatre, BLS training for all the staff, including the OT staff. Your outsourced manpower also needs to be taken care of. You cannot depend on the other agencies, but make sure the health checks and everything is being taken care of. If you're running a canteen, the kitchen workers, sanitation, all these things are important. In medical administration, I think when you go through all these certain standards that are there, I think except for high-risk medications, you don't need to necessarily have GNM nurses, and sharing of consumables between cases is also now certain protocols being laid down for that. Hospital infection committees, I think control, one of the main areas we can all do is whatever taps we're using in different areas is try to mount a plastic extension where you can use a hands-free for all the hand washing areas. Your ICN and infection control officer is the most critical person to ensure that the implementation is being done. Your BMW storage area, that's a small concern, especially with small practices, that where do you store after it, and how do you ensure that it's adequately disposed of, the agency that's collecting it. Adequate PPE for the housekeeping staff, not just using your gloves, but additional safety gloves to be used for them, and even goggles and masks when they're handling the BMW waste. And spill management, that they ensure they're trained with blood spills and other areas. I think regarding medical devices, there is more clarity now as to how often we can use it, and developing your own protocols on the frequency of use and sterilization in between use. Mentioning of allied health professionals, where you can do in-house training for even administering of eye drops, and certain minor assistants like optometrists and ophthalmic technicians who can be given a important role in patient care. Documentation is most important, and informed consent is a very critical area, how you've written your informed consent. I think a lot of discussion gone on to this. Trying to individualize the consent is a major concern, because we do around 40-50 cataract surgeries a month, and if everything looks like a copy paste, then the job does become monotonous. But leaving some space where you can customize a special case, having zonular dialysis and requiring a CTR, where you at least indicate to the assessor that maybe during certain cases certain additional consent is being taken, rather than just having a monotonous process where everybody is just signing off documents. Your discharge summary is very important, and very clear-cut criteria as to whom does the patient contact in an emergency, what are the signs and symptoms of the emergency has to be clarified. And OT and anesthesia notes, I think it couldn't have gone better here. We ourselves probably do 1 GA case in 2 months, maybe 2 sedation cases in a month. And I think it is important for us to make sure that we are following all these legal requirements. Committees and codes, I think it has been well covered by my colleague, Dr. Shakeen sir, and I think we never had even the idea of what a mock drill is before we started NABH. Nobody bothered about having a code blue or a code red. But now once you start the process, the entire hospital is galvanized to it, Today we're talking about code purple for a violent patient or code pink for a child abduction. I think it's important we have these procedures in place, and we know how things are going in certain places where the demands on a medical system have significantly increased. Reviewing the committees, I think just having committees and just having meetings and not doing a proper CAPA is the actual intent of having these committees, is it being achieved? Are we actually in a process of improving each area is important? I think with audits, many times it can be just a completion paperwork process just before the inspection, 2 days being done. I think that should not be the process. Start your audits well in advance. The why of the audit is most important. Why exactly are you doing it? Are you doing it to improve a particular area? Doing an audit where everything is excellent and you have 100% records, or you have 0 errors, you rather not do that audit or don't even present it. Your area of improvement should be done, and once you implement that area of improvement, you can even complete a re-audit to show what you implemented and how did it change or how you were previously working. You can take a very small time as even the waiting time of a patient in the OPD, and how exactly you planned it, what are the areas that you found could be improved on. During assessment, I think you have to have your concerned individuals who are very trained, and make sure they don't take leave at those last days. Make sure they don't quit their job 15 days before the assessment. That's going to be a big mess. Keep all your documentation ready. Don't start searching for papers during the assessment. Bring it in quickly. You'll have fewer NCs. Number of NCs is really not important. If you can have a slight discussion with the assessment team on how you're going to close the NCs is important. For you to quickly identify which are going to be the major headaches at closing, those are the areas you need to talk. And maybe sometimes if the assessment team did not have enough time to do the assessment in certain areas, then you can question the NCs and even remove some of them during the time that you have the discussion. And continuing the exercise, I think for the entire team, reward the entire hospital staff for doing their work. And I think don't have NABH meetings beyond working hours. Try to have it within the afternoon breaks, motivate the team, arrange a lunch for them. Keep them happy, otherwise it's going to be like a painful exercise where they feel that there's just more work being done. Maybe have an early morning breakfast meeting. Well, Dr. Gagan also decided that maybe the fee structure sometimes can be a hindrance for some of us, but as pointed out, I think a lot of us now slowly going the NABH way, CGHS, insurances, and very soon this is going to become one of the required norms. So a few questions that were asked, and I would like to ask the panel, Dr. Gagan. One is, what is the timeline for giving the medical record to the patient?
72 hours. So within 72 hours, and you can give it earlier if required. So whenever patient is giving you a request, the form which you have, you can directly print there that the record will be made available after 72 hours.
One question was, can we provide some of the authorized eye hospital architects names according to NABH norms? I think
no, we don't have any NABH authorized architect, so there is no such list to share. Sorry.
Most of the architects themselves are not aware of the medical issues, so leave alone their hospital designing and principles. So there are few architects and concerns focusing on hospital constructions, but most of them concentrating on more than 100-bed hospitals. For smaller hospitals,
I provided the details and the standard hospital requirement and my requirement. Then he designed the hospital according to
yeah, very often we end up as consultants to the architects.
But we have some template of cookie structure, all that, 5-9 templates that can be given to doctors so that they can discuss it with the architect and all that.
So it's already available. If you pick up the books on hospital design and construction, those templates are there. Standard templates are available.
We are interested in eye.
No, it's not eye care specific. It's all in IPHS, Indian Public Health Standards. It is available for every level of hospitals. So less than 30 beds, 100 beds, 200 beds, 500 beds, medical colleges. So all resources are available. You have to search for the right resource. No, generally, DGHS rule prescribes 3 years for outpatients, 6 years for inpatients, and medico-legal cases till the case is disposed of in the highest court of law. For pediatric patient till they attain 18 years, but basically if they are having any surgery or procedures, it's almost lifelong.
So there was a last question on the same building being used for hospital come residential purpose. I think this will be more with terms of licensing, whether you got the appropriate licenses from the state.
Yeah, we
So
can
the building
use.
construction would be like your typically the ground and first floor what we would build a hospital second. You take a commercial license for that part, and your residence will be on top. So there is no issue with that. It's only which state you have to just take the required commercial license. That's what I would think for that question.
Fire safety as such, hospitals would come under that classification, public safety buildings. So you have to ensure depending on the height of the building. So in some states less than 15 meters, there is no need for fire NOC, but you have to have the third party audit and all the systems in place. But in some states, even under 15 feet, 15 meters, you need to have fire NOC. So this is prescribed by the State Fire and Rescue Services Agency. So in some states, they are very rigid for hospitals. For some states, they are given exemptions for clinics and daycare centers.
We'll close the session. Any more questions? So we'll close the session. Thank you, attendees. Thanks for your time. Yeah, please go ahead.
2 OT tables are allowed as per
Okay, so all of us have trained in that kind of a setup, but if we're talking about any kind of legal part to that, whether it is NABH or state licensing and all, it's not allowed.
So ideally, one patient, one surgical team at a time. So if at all, if you're using 2 tables, ensure that only one surgery is going on with one team attending to that particular
So
patient.
left and right sometimes.
So
will
there
be
should
two
not be
tables.
cross infection and risk of exchanging the consumables, risk of implant being transferred to the next patients. So these are some of the risks that should be avoided.
OT doors have to be essentially 2 leaves or can be 1 leaf.
No, ideally,
Sir, ideal. If you're making a new OT, better to have 2 leaves. If it's an already existing OT with a wide door, then we do with that. So those were the
Norms are agreed.
yes. But it's a question is if you're going in for a new OT, then we should try to put in an ideal system in place. But with old OT, there is no reason to break down the door and put a new door.
All the zones should have 2 leaf doors, not just OT door or 2 right from entry of the OT zone on those doors.
now again, it is linked to the scope of services, number of cases you do, and the area of operations. So without knowing those details, very difficult to prescribe. Okay, so
Last question, sir. AC inside the OT should always be above into AC OT. Or duct AC is allowed. I know window and split AC is not allowed.
no, so this HVAC system doesn't come as standalone unit. It is a comprehensive system where you have the air handling unit, then the cooling system, then the filtration system. All 3 systems put together is the HVAC system. So this is based on certain infection control parameters and also engineering standards, right? So it cannot function on its own separately. AHU cannot function as a unit, and filtration unit cannot be independent of this. So all this have to be integrated properly. Okay, so ductless system is basically what you are telling is the commercial systems, right? So that may not suit into the hospital-based requirement, because in commercial systems there are only 2 filter, 1 filter or 2 filters. So depending on the requirement, where here we need a HEPA filter, so that adds to the complexity.
Okay, so high problem. There is something that proximal filter which is near the edge, what is at the plenum. So if you don't have a filter at the plenum, then the height can be reduced. So therefore,
Now, some engineering modification can be done, but we have to do a proper validation and also
biological.
no, not only biological validation by the engineers. We have to check the pressure we have to check the
Flow velocity.
flow,
Air
and we have to
exchange.
check the laminar flow to the ductules. So all this have to be checked by the engineering people. It is their duty. Our duty is to ensure that that is being done.
The second thing is if you have achieved entry level, and after 2 months, you have the scope of services now, and a plan is made to do a medical retina for cataract services. And how does it stand?
You have to contact NABH for addition of scope of service. So if you are trying to add in between, there will be another visit by the person to your place, and that will be added.
So that is possible.
Possible. Well, other thing is if you have, let's say, 2 months for renewal or something, then you can add that at time of renewal.